Well, good afternoon, everyone. My name is JT Lane. On behalf of ASTHO, thank you all for joining us today for our first ever Tech Expo. In addition to leading ASTHO's population health and innovation work, I've had the pleasure of being a former state health official myself in my home state of Louisiana. And so our discussions today that we've had hold a very special place in my heart. Before we hear from our esteemed National Coordinator for Health Information Technology in 45 minutes, I have the pleasure of moderating our final discussion on data and technology challenges we faced in the COVID-19 response, the innovations we all need to really drive public health data modernization in a transformative way over the next decade. Arguably, the Public Health Data Modernization Initiative could be both the most heavily invested in enterprise, as Mike Fraser mentioned in his earlier comments, but it arguably is also the most groundbreaking change management project we've ever collectively faced as a public health community. Here with me today are four extraordinary experts who work in the intersection of public health, data and technology. First, Dr. Karen Smith, who served as the State Public Health Officer in California from 2015 to 2019. She has spent her entire career in public health data and epidemiology and how we leverage technology in communities across the country and even outside the country, from Thailand to Morocco. Next, Stanley Campbell, who is CEO of Eagle Force Associates and Eagle Force Health. A former Navy pilot himself, his background in physics and mathematics has been used to lead enterprise level design and big data management efforts in defense, homeland security, intelligence, and healthcare. Next, we have Dylan George, who is Vice President at In-Q-Tel, where he leads technical evaluations of life sciences and healthcare projects. He has had roles in, most recently in President Biden's transition team, the White House Office of Science and Technology Policy, the Department of Defense, the National Science Foundation. And finally, Jared Allgood, who is co-founder and Chief Strategy Officer for Healthy Together. He is a trusted advisor to many states and other organizations and businesses on COVID-19 vaccine management, case management, and health and safety processes, protocols, and solutions for safely reopening or returning to work. Full bios on each of our speakers, as before for other panels, are available in the Texpo event platform. So thank you for all for being here with us. So to get started with our discussion, as we reflect, for our four panelists, as we reflect on the discussions I think we have today, the issues, the solutions we've addressed, the ongoing issues that maybe need more attention, and as we consider, I think the five big picture components of public health data modernization, which include enterprise level solutions, interoperability, security, workforce, and finally public-private partnerships to fuel innovation, which we've touched a lot on many of these topics throughout the day. Could each of you take 3 to 5 minutes, I think, to share your perspectives on one or a few of the initial challenges of the COVID response, the digital and technology solutions that address them, and how these innovations might be applied in the future. So differently, at the end of the day, what lessons learned or innovations from the response should inform our long-term modernization vision, or as Dr. DeSalvo put it earlier, inform how we build a 21st century digital infrastructure. So before we get started, to our Tech Expo attendees, be thinking of questions to ask this fine group. Dr. Smith, as a former state health official and alum of ASTHO, I'd like to start with you, and then we'll turn to Stanley, Dylan, and Jared. So come on down, everyone.
Thanks so much, GT, and thank you to ASTHO for inviting me to join the conversation. But especially, it's such a great opportunity for me to thank all of you colleagues in public health for all your work over this last truly unimaginable year. I have been very fortunate over this year to have had the opportunity to work on a number of pandemic-related projects with several teams at Google. It's been, without a doubt, one of the most fascinating experiences of my public health career. And I thought I'd share with you some of my impressions about the differences and similarities that I noticed between working in tech and working with governmental public health, which is where my career has been, and then a little bit about the future that I see. So just in terms of some of the differences, the language we use is very different and sometimes a little bit surprising. The first time I used the term surveillance in a conversation, I could see a visible impact of that word, and not a good one. Surveillance for most of us in public health just means monitoring disease trends. It's what we do all the time. But in a world that's under tremendous scrutiny around consumer privacy and targeting, you can imagine how that term might resonate. So I've come up with a whole bunch of different synonyms that I can now use. Also, if I'm any example of a typical governmental public health person, most of us in public health don't know much at all about how technology companies work. And my experience with now a year of working with folks in tech, like most of the general public, they really don't have any idea what public health does. Actually, many of them have more of an idea now. But to start with, not really understanding what public health does, why it exists, and certainly not governmental public health. In fact, most people, I think, don't understand what government does, how it functions. And that's created some challenges, especially early on, in figuring out how to work together. And then finally, the most obvious difference is that technology companies do have a profit motive. And while we in governmental public health, we are literally precluded from making a profit. So that's a pretty substantial difference. But in many ways, I think the similarities of how we work and how we think about what we do outweigh those differences. For example, the most important tools that both technology companies, but also public health have, are our highly skilled and specialized workforce and our data assets. Those are crucial to everything we do. Also, public health takes privacy very seriously. And throughout my experiences this year with Google, protecting consumer privacy is absolutely of paramount importance to tech companies as well. But most important, I think, for me, I have met and worked with many incredibly powerfully mission-driven people, both in my work in government and happily over this past year in technology companies. We have that in common. We really want to do good. And it's not a cynical good, but really wanting to do good for the world. So I think that these and other similarities combined with what tech and government together have already done throughout this pandemic make me very optimistic. Well, let's just say modestly optimistic about what the future could look like if we continue to work together. I think it's very important that this conversation continue. As much as we all would love to take a few days off, get some sleep, just get back to normal, we will be able to do that. But as far as normal goes, I think we've had a number of months now of seeing just how inadequate our public health normal is. If we could have thought about what's the situation that we would find ourselves in that would make our inadequate infrastructure, both human and technology, incredibly obvious to the world, this pandemic's done that. But perhaps more existentially important, think about how much better we could do the work that public health wants to do if we had the tools that we've now seen applied to this massive public health problem of a worldwide pandemic. What if we truly had interoperable data, not just public health data, but municipal data, environmental data, all kinds of data that apply to the problems that public health addresses? And what could we learn if we applied the powerful analytic tools that drive every predictive model and dashboard that's been created for pandemic? And what if we applied those tools to the interactions between biology, environment, behavior, and opportunity that we believe create and sustain healthy people in healthy and resilient communities? Finally, what would we learn about how well our programs and policies work and for whom they work? Those are all things that we can learn with more of the tools made available to us, more of the data made available to us. And think about this. What if we could engage and activate communities around their own health by providing them direct access, easy access to ongoing information in understandable formats about the things in their communities that are challenging their health and well-being, as well as the assets that they have that strengthen those. What if we could give people communication tools and information that would then empower them to better engage with their policymakers in their communities to create policies that work to improve the health and well-being of everyone in their community? But we're not going to see these benefits if we retreat into our silos again. And I really think it's critical that the ongoing conversation be co-convened by public health and technology companies as equal partners. We need to start the way any coalition starts. We need to better understand each other. We need to understand our respective values and constraints, and even how we work and our language. That's how we can build trust that will create a powerful partnership, I think, for the future of public health, as well as the general good. And so I'm actually optimistic about our future, but we can't just be passive. We can't expect it to happen without us reaching out and actually doing the work of creating that partnership. And I'll stop there. Thank you very much for the opportunity.
Thank you, Karen, and thank you, JT, for having us here. As it relates to those things that we've been able to see over the last year, we've been involved with standing up small COVID operational sites, large COVID operational sites. Our day job in the field of healthcare is we monitor in real time at every point of sale pharmacy in the United States and 4 of the territories. When we look at that, that's technology that, as Dr. Smith referenced, was built on the platform of a coalition. That coalition was NATO. And as NATO goes to fight, its fitness to fight on a nation-by-nation basis is one of the most secure assets for that nation, meaning, and we have to be able to share both openly and as well to be able to protect data. Clearly, the United States shares at a different level of trust and responsibilities with England than it would do with Turkey, as an example, even though both are NATO nations. So those issues associated with what 21st century medicine has to have and what COVID has actually forced us to do at a pace that is overwhelming as it relates to interoperability, information sharing, the ability to have privacy as a core competency of the value proposition. Those are the things that we've been challenged to do. And to a large extent, we think we've met those challenges under this kind of this concept of the MyVax platform. When we look at the biggest challenges, they represent themselves in a way that we've already known, but we were not able to quantify. Health disparities in the minority communities, health disparities with those migratory workers that are first line of defense as it relates to agriculture, as an example. Though we did an extremely good job on vaccinating healthcare workers, our food supply system, which really represents our first medicine, those people were disproportionately left out of the vaccine. And then as we put rules and regulations associated with state and territorial boundaries for vaccine dissemination, we failed to look at interoperability, where that population of people is migratory in nature. And then what we got is exactly what we should have expected. We have a disproportionate element of death associated with that, and the hardship associated that comes with suicide and other things that being socially isolated and being restricted with not a lot of help. We can talk all day all day long about the issues associated with technology in the 21st century infrastructure. But that does not do Ms. Jones sitting in Miami, where when the vaccine came to Miami, we wound up with Twitter being Miami, Jackson Memorial Hospital's method of dispensing the information. Now, I'm from Miami. I actually was born and raised in Miami. I came directly from Liberty City. And I can tell you without a doubt that not very many people in Liberty City have Twitter accounts. And so when we look at what the next generation of healthcare, what 21st century medicine looks like, it's got to be able to incorporate environmental, social, the ability to send sensors home, because there's now, we talk about mistrust in vaccinations, there's not a lot of trust in nursing homes anymore. So we're going to have a much larger population that is going to age at home. What does sending sensors home look like? What does those overlapping services where we would have wraparound services? COVID showed us lines and lines of food as a problem. How do we incorporate social determinants of health? What do we learn from COVID? And then how do we fix these things in a way that we get permanent fixes where interoperability, information sharing, and vaccines are shared? So if you could run the video, we'll show you what we're doing in partnership with Miami to actually bridge some of these gaps. Well, looks like they may be having a little bit of issue with running the video. In any case, you guys can actually download the, oh, there we go.
The city of Miami is collaborating with MyVax. We are highlighting the fact that MyVax is now available to be downloaded for free by people to have all their electronic medical records available to them. And they are also working alongside those Miami residents with their insurance to distribute 50,000 phones with the app, which will have essentially 2 years of service that will be paid for by that program. We live in a world where our healthcare records have never been more important. We obviously know what's ahead of us in terms of what this country needs to do to get through COVID. And one of the big things that we're going to have to do is something we've never done in our history, which is vaccinate potentially the entire population of the United States.
Using MyVax can help allay these fears because it empowers people to work with their healthcare providers and help monitor their own care.
What it's doing is giving people who not only don't have access to technology into their history, but those who don't understand the necessity of having such perfect information to give to your doctors to make decisions about your life. And we're going to do all that we can to ensure that people have the access to quality healthcare that they need right here for the residents of the city of Miami.
So thank you. So for the fully operational environment as it relates to the things that we're doing, we're partnering with Apple as an example, where smart devices are able to be provided. We're partnering with doctors and others, with Johns Hopkins and others in the health community, such that a provider can actually write a prescription and have us with the ability to give those 50,000 is now gone to 2.5 million smart devices. And we're absolutely on pace to be able to do 20 million smart devices. Because today, if you're an elderly person and you don't have access to the internet, and you can't do a telehealth visit, you don't have access to healthcare to a large extent. We've made these devices available to community health workers across the nation. We've made the platform available, myvax.com, for free. And as such, the ability to use that platform, not just as a means, a method, and a modality for tracking and contact tracing, but to be able to put your COVID tests and put your vaccinations in the same environment. When we pivot next to who is the sickest of the sick, so as to be able to help in the triage. It doesn't make sense to have a 50-year-old healthy as a horse and a 22-year-old with asthma, and one gets in front of the line of the other. We're as a nation, we're doing an extremely good job. I can tell you from the front lines, as we see, we're doing an extremely good job of getting the vaccine available. Where we're not doing a good job is getting that into those disproportionately affected communities. And what we're flat out failing at is how we're dealing with migratory workers. So as we on this panel open the doors to what is the possibility of 21st century medicine, let's make absolutely positively sure that we absolutely do not leave those people behind, because technology is an enabler, can also be technology that widens the disproportionate nature of how healthcare is administered, how social services are administered, how nutrition is monitored, and how the inference of sensors into the next generation of healthcare could actually widen the gap. So thank you all, and we look forward to the discussion.
Thank you, everybody. Really appreciate the opportunity to be with you all today. It is an honor and a privilege to be on the panel with such an esteemed colleagues, and I very much appreciate ASTHO and the great team that JT and his colleagues have put together to bring this actual meeting together. Just a couple framing comments, and then we can move on to the other panelists and then some discussions. But you know, we definitely live in an age of pandemics right now. Over the past 10 years, I've been trying to convince people that this is true, and it's a self-evident truth now. And as it continues to rage, and it's painfully clear that our communities, our loved ones, and collectively as a people, we've all been impacted significantly by this. But you know, pandemics are and will continue to be with us going forward. This administration will face more, if not multiple, public health emergencies during its time in office. And we need to meet this current moment, as I think that we are, thankfully, but we also need to prepare for the persistent future threats. You know, it's been very exciting as well that we live in this age of emerging technologies, and notwithstanding the challenges of the economic and equity divides that emerging technologies can provide or exacerbate, as Stanley just mentioned to us, there are prominent opportunities with the data revolution. Artificial intelligence, quantum computing, cloud compute, mobile devices all give us really interesting opportunities. Data technologies have transformed our society, but they have not really transformed healthcare nor public health. And so, you know, so we need to figure out how these persistent problems with data and how to overcome them as we're going forward. And, you know, we've all seen the multiple failures of data during the pandemic, and until recently, the volunteers and the academics that have been providing timely and better data than the official sources have been our source of truth in a lot of these ways. I mean, we've all used the Johns Hopkins University site. We've all used COVID tracking project to help us understand what's happening with the virus and what's happening with the response. And, you know, it's been humbling, inspirational, and inspired to see those people stepping into the breach and helping out. And it's, you know, we're all better for it. I feel like I'm joining a chorus of people and in making the comments about trying to improve our capabilities with the private sector going forward. You know, it's very interesting to me in the United States, we have explicitly accepted the need of private sector involvement in manufacturing vaccines and drugs. The Pfizers, the J&Js, the AstraZenecas of the world have helped us really bring vaccines to sorry, my audio for a second there. But COVID has demonstrated that we similarly need to be explicit about the need for private sector involvement in data systems to guide public health responses. If vaccines are mission critical and we lean on the private sector to build them, why are we not doing the same for mission critical capabilities like data systems for public health? We're in the 21st century and we need 21st century solutions to these problems. And so I just, again, to wrap up, there's two main recommendations that I would make is that, and these are just, like I said, joining the chorus of people that have said these before. It's like, we need to figure out new ways of engaging the private sector and civil society more effectively to transform our government and public good capabilities for pandemic response. And I'm so grateful and encouraged that the current administration and we have funding and resources for modernizing the data systems and analytics to speed up the pandemic response going forward. I'm cautiously optimistic that we're at a better place now and we have the capabilities to move things forward. And so I'm very excited that ASTHO is bringing this group together and for the opportunity to chat with you all on this panel today. So thank you very much.
Thank you, Dylan, Stanley, and Dr. Smith, and ASTHO and JT for bringing this panel together. We're newcomers to this space. So my name is Jared Allgood. I'm the Chief Strategy Officer of Healthy Together. We are a public health technology company with teams based in Florida, New York, San Francisco, and Utah. And what we're bringing to the market and have been since the pandemic started is a holistic approach to public health technology. We support web and mobile platforms for resident engagement to support everything from testing to test result delivery, contact tracing, active monitoring, vaccine registration and scheduling. But we also provide systems for supporting public health officials. So think about case management systems, epi-surveillance, immunization information systems. And then speaking to what Dylan has just been calling out is an emphasis on the integration and extensibility of data throughout these systems. So since the pandemic started, we've worked with dozens of states on strategy. We've deployed our software in 3 different states. And we have millions of US residents who are using our mobile platform. We've got residents in every country who are on it. And we've delivered millions of COVID test results. We've performed hundreds of thousands of contact tracing interviews. And the perspective that I want to bring to the panel really is kind of a look forward and a look back. We got to come in and see public health, I think, with fresh eyes and see the systems and the technology and the strategies that were being deployed. And then we've been partners with states trying to bring these systems, technologies, and strategies, into the 21st century and into a post-COVID reality world. Some problems that we saw as we came in were things, simple blocking and tackling things like how do we get information directly to residents, where and how to get tested, should I even get tested? We came in and helped states extend their case management systems so they could support thousands of new people who had never done contact tracing before, perform a job that had never been done at that scale. We see problems in terms of scaling manual contact tracing, active monitoring, which is the tail end of contact tracing, which makes it effective. We saw that many states and local counties had to give up active monitoring. These are just some of the problems. How do we connect data systems so that where data is being collected, it's seen by public health officials in real time? The idea of batching data seems unconscionable now, given how important it is for us to move and go quickly. And so that's the perspective that we want to bring. Looking forward, we see several opportunities. Public has changed the relationship. There's been a paradigm shift from public health to the residents that we think is going to exist forever. Public health should have a relationship with residents. And we saw that happen in states like in the state of Florida, where close to 40%, just over 40% of people who were given the option to do a contact tracing interview in a mobile experience chose to do that. So that contact tracing could be completed in an average of 2.5 hours from test result delivery rather than 25 hours or 48 hours. Data relationships between entities, both state entities like counties and states, we see that changing and improving, but we also see non-traditional entities who are going to be sending data back to public health as they participate in broader public health response, schools, employers, and the such. So maybe I'll just pause there and stop there and just say, I'm excited to be part of the panel and looking forward to the discussion.
All right, if we could get all our panelists back and start our conversation. We've really got some really wonderful questions from the audience. So I'm going to dive right in. The first one I think is a good question for us to cover, and it's really around the national blueprint. So how important do each of you think it is or is not to have a national blueprint for public health data modernization? I think that probably assumes more of a roadmap beyond the strategy and vision we've set, but sort of an implementation roadmap. And so how important is it that we have that? And what role does the private sector have in that modernization?
I'll jump in.
Go, Jared.
I think I think the importance of it is hopefully it's self-evident. As we coming from the private sector, being new to government, we could see that everybody who's working in government wants to point to a source of authority that indicates that that the strategy that's being taken is aligned with science and data that indicates that they'll be successful, or some kind of guideline that comes from somebody that's above them. And we've had conversations with individuals both at HHS and CDC specifically to call out the need for updating the guidance and the recommendations that are coming from these national entities, not so much necessarily as mandates that come down to states or counties. States and counties are going to make choices about how they apply guidelines and recommendations, but it's powerful to have national entities, the federal government, come in and outline and highlight what has been successful, show analyses that prove that some of these modern techniques, in our case, we would submit that automating certain aspects of a manual process like contact tracing can be effective both at adding speed and scale to the response, and also reducing millions and millions of dollars in costs. And it makes it easier for everybody who's in a decision-making position to point to some authority to say that that is the proper guideline. And then the second part of your question was around what's the role of private private industry, and I think Dylan called this out effectively. I think historically, as we look at technology projects that have happened in public health, they fall into three buckets. You have in-house projects that are built in-house, consultant-led projects that can kind of spiral out of control in terms of time and costs, or you have some SaaS product vendors who take an off-the-shelf product and are trying to shoehorn it into a public health solution. And I think the thing that's changing now because of COVID, obviously, is that there are companies like ours who are investing tens of millions of dollars in R&D, design and research and development to be able to deliver solutions that are tailored specifically for disease response, pandemic response, or specifically for the broader public health infrastructure. And I think that's what's the role of private sector, in my view. It's to do what the private sector does best, try and compete and build the absolute best product possible to meet the needs of a specific customer. And I think that's something that public health hasn't had historically because of the ways that these projects have been funded in the past.
Yeah, I'd like to echo a good bit of that, but I'd also like to ring in on one of Karen's comments. I'm doing this interview from our National Command Center, where we message in and out bidirectionally within every point of sale pharmacy in the United States and 4 of the territories. We already have a script standard that carries into account every medication, every provider at every point of sale. These are systems that do not exist in the government environment. However, what you see scrolling behind me is coming in real time. So when we look at what West Virginia did and moving not from the the methodology described by the National Platform Perspectives of CDC. They actually just handed the information into an infrastructure that is already built in scale. We already today, without COVID or any vaccine, do 4.5 billion pharmacy transactions a year, and a vaccine is just another NDC. We do that with every provider, 1.2 million providers, but we limit providers as it relates to what we had available. The infrastructure is there. Then we look across lines. Every state, this ASTHO conference, every state official on this call has a PDMP system, prescription drug monitoring system, and they have to do MOUs between states to share data. Even though at the federal level, under the Anti-Kickback Act statute, we have to be able to look across state borders because of Medicare, Medicaid, and any other system that might divert federal dollars, i.e. through coupons or co-payments where you move a person off of one medication onto a non-formulary medication and the government has to pick up the tab. So what winds up happening is these infrastructures are there. The regulations sometimes are competing with each other, and though I think it was Karen again who made an implication on public-private partnerships, and I think JT mentioned that also in his introduction. We've got to be able to do the reach, but the reach has got to be beyond just going to Google or just going to Apple or just going to the bigs. There are those of us who are in industry who absolutely, positively can actually bring a different perspective. And I think those are the kinds of things that we've got to be able to open up the aperture a little bit so that we can actually get more creativity.
Yeah. So you quoted, I think, Dr. Smith twice. So I think she wanted to go next. So I'm going to go right to her.
Okay.
She's so good.
No. So just speaking from back to the question, does it need to be sort of enterprise-wide, or do we need a roadmap? I think what we need is a national agreement on what a minimum set of what does it look like when it's built, and I don't mean who built it or the specifics necessarily, but I mean what does that 21st century digital infrastructure look like? And then I think that, and this is true, we have seen what happens when you build systems that don't talk to each other with hospital data, for example. So public health data is very different than medical data, but we still have to have standards. And yet what we've done in the past in public health is get bogged down for years in wordsmithing standards, et cetera. We need to speed that up, and we need to have other people in on that conversation. And I agree. I think most of the infrastructure can be built and perhaps should be built outside of government, because government is so awkward at that sort of thing. And so that's actually a really important partnership to have. But those of us who have to access the data and use the data and understand the intent of the data and how to what it reflects have to be in on the conversation of what that needs to look like, because it isn't the same. And people are always making an analogy between healthcare data and public health data. They're radically different. And in many ways, public health data, because it is made up of so many different kinds of data, is much more complicated. That doesn't mean it's not doable. I firmly believe that it is.
Yeah, the only thing I would add to this excellent discussion point, though, too, is that I think that for the blueprint, I think setting requirements, or essentially the decision framework, what are the actions that people want to do with the data, and what is the evidence base that needs to be presented that would be compelling to decide on what should happen or what shouldn't happen. That should be really firmly embedded within the public health environment, and they should really set that going forward. How we actually implement different sorts of technological solutions should definitely, we need to lean on the private sector more than we have. And I firmly agree with Stanley in that it's really challenging for other entities, other small businesses, or startup companies to engage with the government. It's not is typically not on their roadmap. It's typically not because it's a fairly small market, and so it's challenging to engage. So we need to think of different mechanisms to do that. We did this within medical countermeasures. BARDA, the Biomedical Advanced Research and Development Authority, was specifically developed to enable the private sector to work more effectively with the government. And I know that the ONC has been doing some of that as well. But we need to, I think, take some lessons learned from what BARDA did. I think that there's still work associated with BARDA, but I think that that's one of the things that they've done well.
Yeah. Well, I could go, I think we could probably talk about this for another hour. And I want to thank each of you. Maybe we will pick this up before the next Texpo and be able to talk about some bigger ideas that we've fleshed out that will be helpful for everyone in the community. I think that can guide both, the tech sector and how the right way for them to engage public health in new ways. Likewise for public health. We talked a lot about engaging communities in easy ways that we're reaching them. Whether it's communities, local communities or the private sector of the community, I think is really one that is we're going to have to do a lot of work on, because we're going to need those relationships beyond a typical procurement construct, right? It's how do we find the strengths of each to sort of really use that to fuel innovation and modernization in a really strategic way. So I'm looking forward to picking this up at some time. So I want to just thank each of you for your participation today, for your time. Thank you, Dr. Smith, Stanley, Dylan, and Jared. I think I hope everybody will report in the evaluation your wisdom was essential for today and our success going forward, and we will talk another time. So with that, our closing keynote speaker has joined us, and we're very excited to hear about what he has to say. So now it's my pleasure to introduce our U.S. HHS National Coordinator for Health Information Technology, Dr. Micky Tripathi. He started day one, hour one, January 20th at 12 p.m. He has over 20 years of experience across the health IT landscape. He most recently served as Chief Alliance Officer for Arcadia, a healthcare data and software company focused on population health management and value-based care, the project manager for the Argonaut project, and industry collaboration to accelerate the adoption of FHIR, and a board member of HL7, the Sequoia Project, the Commonwealth Health Alliance, and the Karen Alliance. He holds a PhD in political science from MIT, a Master of Public Policy from Harvard University, and an AV in political science from Vassar. So with that, Dr. Tripathi, welcome to the ASTHO Texpo.
Great. Thank you so much. Just really delighted to be here. And, as you pointed out, I joined on minute one of the administration, which was in January. And that was about 30 years ago, I think, in terms of, sort of the number of things that we've going on and and also, sort of the excitement of the opportunities here and the ability to help. Really look forward to engaging with the ASTHO community, and already ASTHO's been just tremendous partners, both for a number of years with ONC obviously, and then just in my short time, I hadn't had a whole lot of interaction with ASTHO before joining ONC, but have I've had a number of opportunities to engage with ASTHO, and it's always been a really rewarding experience, and look forward to deeper and broader collaboration going forward, and benefiting from all of your expertise and advice. So I thought I'd talk about a few things related to what we're doing in the area of COVID, and then move to to other things that are very important for all of us as we think about the future of interoperability. Some of it that sort of draws from what we're doing for COVID, and then that thinks more broadly about sort of interoperability and where we want to try to head. And we'll try to sort of focus on areas that are most specific to public health, since that's this group. So, a number of things that we're doing with COVID. I mean, one, I think, I've engaged a number of members of the ASTHO community already about this, but I want to make sure to not to make sure that I use the platform that I have right now to just do a call out for work that we're doing, which is really kind of a campaign related to scheduling. One of the things I think that all of you have, no doubt have seen in your own lives, or have certainly seen across the country, are the difficulties that people have had with scheduling vaccinations. And you may recall President Biden's, in his last talk, talked about the May 1st eligibility date for everyone to be able to get a vaccine, and also for being able to, help improve in some way the vaccination scheduling, experience that individuals have had. So we, along with our partners at the U.S. Digital Services of the White House, have been trying to engage as many stakeholders as we can across the country, both with respect to government officials, state, local, territorial, tribal government officials, as well as other organizations like ASTHO and CSTE and and other key stakeholders, to just raise awareness of the opportunity to help to incrementally improve scheduling capabilities with a FHIR-based approach. There are some states that, because they had to move ahead, they were moving ahead, and they were thinking about a proprietary specification for the ability for to be able to expose or show to an individual how many appointments might be available at a particular location. And what we're trying to do is just to raise the awareness that there is an approach to do that that aligns with nationwide standards, namely a FHIR standard. So we've been, on a campaign working with a variety of vendors and other public health professionals, as I said, and governments, to just raise the awareness that this is available. We've worked hard with HL7 to make available a specification and that aligns with all of the FHIR specifications that that we've tried to or that we will require in electronic health record systems. It's already a part of regulation, just hasn't gone into effect yet, and that'll give us all sort of something to build on, and something that's aligned with the $40 billion base of electronic health record systems that all of us have invested in over the last 10 years. So ONC will be sponsoring a connectathon of the willing, a coalition of the willing, as it were, of vendors that want to test in more of a synchronous way the specification, and we'll be announcing that sometime shortly, but it should be in the next 2 to 3 weeks, and we'll be partnering with the U.S. Digital Service on that. And would really love if any of you on the phone or would participate in that, or if you could just let your stakeholders know, because this is one small way that we can hopefully improve the scheduling experience that that people are having, and see if we can make it a little bit better. The other thing that we're spending a lot of time on is the executive order on public health data systems. We are co-leading a work group with the CDC to look at the public health data systems. I think the name of the executive order is Ensuring a Data-Driven Response to High Threat Public Health Threats, or High Consequence Public Health Threats. I think that's the name of it. And so we've launched that work group, and work is underway, and I think that could be a really important sort of a thing that we do over the next year with the CDC to help to sort of reframe perhaps a little bit of the way we're thinking about sort of public health data systems as we think about it today. And what I would love is that if we sort of move from thinking about public health data systems to a public health ecosystem, and how do we move get from where we are today to that. And I think there are a number of dimensions to that. Along the way, we want to be able to take stock of the experiences that we've had in this pandemic, and the experiences that we're still having. We're obviously not out of the woods yet by any stretch, and so there's a lot of lessons learned there. I think, as all of you know, that this experience has shown us things that have worked and that have been made to work through some of which in the ways that they were designed, sometimes through brute force, and some things that haven't worked, and have sort of shown a little bit of light on things that haven't worked. So we want to be able to take stock of all of those things, and then see what that tells us about what the public health ecosystem of the future might look like. And that relates a little bit to the work that we at ONC do on an ongoing basis. And, a lot of that is related to, to interoperability. And as we think about, the investments that, again, all of us made in electronic health record systems since 2010, we've now got that foundation laid. Well over 80%. I think among hospitals, it's well over 90% of providers have a certified electronic health record technology that they're using every single day. And that's a huge foundation now that we can start to build on and make use of. And one of the challenges, I think, and the 21st Century Cures Act that many of you may remember was passed in 2016. I like to point out was passed when President Obama was president, because that sort of to me that sort of is much more vivid in terms of how long ago that was. But that was passed when it was signed by President Obama in 2016, and the April 5th applicability date of that is coming up just around the corner. And, we're looking forward to working with industry on that, because that is, sort of the first swinging into gear, as it were, of the, of the 21st Century Cures Act that, that had a number of things in it related to information blocking, as well as TEFCA, the interoperability framework, and, sort of a real call to action for APIs. And the ability to access APIs without special effort for a variety of purposes. I think all of that, helps to contribute to this idea of a public health ecosystem as we go forward, which is to say, to break down as much as possible the silos that we have right now, I think, between public health systems, which we think about as public health systems that, are owned by the CDC or owned by state health departments, and, being a, mostly a one-way channel of information that is reported out of systems, to something, and then you have clinical systems that exist in their own silo, and not that much interaction in a way that would allow us to really think about that as just being a part of an integrated ecosystem, not something that not things that only have sort of very, very selective touch points. And so a lot of the what I want and hope will come out of sort of the work that we're doing with respect to information blocking and TEFCA and APIs will help to enable the ability of creating that ecosystem. So what do I mean by that, and how does that happen? Well, one of the things that I think has been something that the industry hasn't gotten enough credit for is that there is a lot of interoperability that happens right now, and it's a shame, I think, that the industry doesn't get more credit for it, because if you think about the nationwide networks like Care Quality, Commonwealth, the eHealth Exchange, and all of the the volume of traffic that goes over those networks today, that's there's a tremendous amount of work behind that, and it serves a variety of purposes, both with respect to connecting providers with each other, as well as with federal government agencies. And but that lives in its own silo, as it were, because those networks are really focused almost exclusively on treatment purposes. And so that's one of the reasons I think that the industry doesn't get enough credit for the interoperability that's in place, is because it's really, sort of has been relegated just to treatment purposes and hasn't broadened to encompass other purposes that are important to healthcare delivery as well. I think the other reason that the industry doesn't get enough credit for the interoperability that has been accomplished is because there also is a lot of activity going on in HIEs, state, local, regional HIEs, but those are pockets, and there are there are certainly success stories, and there are a lot of less successful stories, and we haven't really been able to sort of tell the right story or the full story about how did those integrate with each other and with a broader network and a broader ecosystem. So that's one of the things that I think is really important for us to accomplish with TEFCA, is to sort of say, how do we broaden the the ability to use that in a way that's easy, but also takes account and encompasses these other really important use cases, public health being one of them. I know we're in lots of conversations with our public health colleagues who understandably lament the inability to be able to get the kind of clinical information that would allow better public health decision making, and yet we just peer over the over the wall at the torrent of information that's going through these these nationwide interoperability networks and other networks, And you just see the siloing and the effect that has on the ability to be able to use interoperability in in more fundamental ways, and the inability to use it on the on the public health side in ways that that were a part of the hopes that we had for when we embarked on this large journey of spending a lot of money to make sure that interoperable electronic health records were in place. So that's one of the things that I hope that we can accomplish with with TEFCO, is to broaden the set of permitted purposes and the exchange purposes to enable a wider variety of transactions to happen, to better everyone's capability to serve patients better at the end of the day. The other thing that I think with information blocking that will hopefully open up, sort of more of an attitudinal change, which is harder to accomplish, I know, and it doesn't happen overnight. But I think we need to, sort of work really hard to, essentially flip that ability to that starts with, sort of an attitude of sharing only if of not sharing unless I find reason to share, or unless I unless there's an exception, to sharing unless there's an exception. And I think I butchered that, but hopefully you know what I mean. And what we want to be able to do is really flip that paradigm, right? So that we have sort of an innate and instinctive sharing for authorized purposes that starts to embrace other parts of the healthcare ecosystem to be able to have that kind of interoperability that we all need to serve public health. Since there's a lot of public health stakeholders here as one incredibly important sort of set of stakeholders and capabilities that we want to be able to build. APIs are a really important part of that as well, because we can't have the kind of rich patterns of exchange and the ability to have users be able to take advantage of information that might be available from public health systems, integrate into their workflows without better technology to enable that. The standards that are mostly in place right now serve a particular purpose, but it doesn't allow for that rich kind of capabilities that Firebase capabilities, for example, can offer in the way of capabilities like like being able to read and write, and the ability to have CDS hooks or Smart on Fire apps integrated into the workflow of the EHR system, so that you can bring in information and usability experiences from outside and be able to do all of that within your EHR system. I think we're just at the sort of the tip of the iceberg of the capabilities there, and the public health community I think has a lot to offer in that once those patterns get more fully established and we start to really see what we're able to do there in the way of apps that could be about enabling better interactions with public health agencies, as well as patients being able to work more directly with providing information to public health agencies and getting things back from public health agencies as well. So another big part of what we're doing is also aligning with federal partners, and we're doing, as I said, a lot of work with the CDC. We really want to sort of lean in to all of the federal partners, the CDC being a key stakeholder. We also welcome opportunities to work with state health departments, and we're always open to hearing of any interoperability or standards issues that you think that National Coordinator's Office can help with state or local health departments. We're always open to those discussions, and happy to be helpful in helping you and CDC colleagues be able to take the best advantage of standards and interoperability to accomplish your needs, and to be able to work with other federal stakeholders on that. We also, working a lot with other federal partners as well as a key part of everything we want to be able to do at the National Coordinator's Office. I didn't appreciate, I think, fully once, having been 20 years in health IT from the outside, of what a big challenge and a big opportunity it is to be able to work with the other federal partners and to be able to, try to make sure that we're doing everything that we can to allow them to have standards and standards-based interoperability capabilities and other capabilities to help them further their goals. So we're spending a lot of time making sure that that we're doing as much of that as possible within the federal government to benefit everyone on the outside who interacts with the federal government in all of its various guises. That hopefully we can be all rowing more and more in the same direction on that, and helping the industry to move forward as well. So the last thing that I would just comment on, and really this is really an opportunity that I would love to get your input on and your feedback on, are how can we improve the ways that we think about health equity. And there's certainly the thoughts related to getting better data. I think we're all focused on how do we get more structured data that reflects reflects better demographic information that would allow us to have better measurement of health disparities, because it's difficult to attack health disparities if we don't know exactly where the issues are and where to allocate resources. But also, how do we think about that in more deeper ways, as we think about how we take data and turn that into information and turn that into action. All across the the healthcare delivery system, as well as thinking about how that goes across the public health system as well. And we're really open to all of your ideas on what are the best ways to do that. We're kind of just scratching the surface here, but that is a top priority for us to be able to think more and more, both within ONC as well as with our federal partners, about how do we build in health equity as a key consideration, health equity by design, as we think about all of the things that we do going forward, so that all of the systems are sort of natively designed to be able to take into account health equity considerations, and then we're able to make much better progress than we've been able to make to date in that dimension. So I welcome all of your thoughts and inputs on that. We are open to all ideas, and really look forward to your questions and comments and to discussion. So thank you very much. I really appreciate the invitation to be here, and thanks again for coming and allowing me to be here.
Thank you so much, Dr. Tripathi. I was wondering, we have a few minutes for some additional discussion, a little bit to pick up on the health equity component, if you have some time.
Yes.
Yeah, so I was really struck by it. I was thinking about it the other day in terms of the importance of getting this right, so that we, if we think about it, we use data to plan interventions or programs. We use then use that data to sort of set baselines or try to measure the right things, so that we can get a better sense if we're making progress. What do you think some of the, and I think it's a critical part. You can't have a solid strategy on equity without a solid system in place to measure it and to plan from it. So what do you think some of the barriers are that we should be thinking about that as a community long term?
Yeah, I mean, it's a great question. I guess, one thing that comes to mind is, having, again, lived on the other side of this for 20 years in health IT, and just seeing on the ground the challenges with, with just simply saying, well, we just need to have more structured data and more structured data capture, and then all the information will start flowing, and then we'll have better ability to measure. And that's kind of where it stops, right? It's like, oh, we have the, somehow naturally the better ability to measure will turn into actions that, from my perspective, it's whole challenges along that whole thought stream. One is that there are serious workflow issues related to capturing better data. A lot of it is related to just the pressures on the people who are expected to document that kind of information. A lot of it is related to the very fine balance that I think we have to strike between the hesitancy that people will have about providing that kind of information. I think one of the things that the pandemic has uncovered and has been, sort of a shock to people who live outside of the healthcare system is, well, why don't we have, good race ethnicity data on labs? And it's like, well, because when you show up at a lab, you don't expect them to ask a whole bunch of questions about your demographics, and they don't. I mean, it's not required for them to get paid. And for many people, that would be considered a very awkward interaction. It's, I just want to get my blood drawn. I'm not here to provide you with all of that information. And so I think we have to think really hard and judiciously about, first off, all of the flows of information, and how do we be judicious about what information we really think we need in order to take actions? Because I think, we might have a tendency to just say, well, let's just keep broadening the funnel, get as much information as we can, and then we'll figure out how to do it. We'll figure out what to do with it. Where, I think I like to focus more on, let's figure out what we would do with information and then work our way back and then ask for the information so that we know that the information that we're going to get and that we're asking people to spend time getting is actually going to turn into actionable things that hopefully they see the benefit of.
Mm-hmm. Yeah, that's helpful. I was curious, as we think about the long-term implications of modernizing, not only for public health and technology systems and tools, but the impact on public health practice that could help. Technology is ubiquitous, and so it's all around us. I guess, what's an easy lesson, or what is that saying? What do you think? Is there something that jumps out at you from the response thus far that we should learn from that we absolutely can't miss for future planning and implementation? Like, is there a lesson that sticks out for you that just, no matter what, as the money gets spent and planned for, that, you might tell state or local or jurisdictional agencies that, don't miss this thing for sure?
Yeah, that's a great question. So a couple of thoughts come to mind. One is that I think one of the things that we've seen is that the jurisdictional issues that we have related to public health, gathering and using and implementing public health actions are really, are really difficult. And everyone knows that, right? Everyone knows that. Yeah. But I think that when you have this crisis, all of a sudden a real harsh light gets shown on it, and people start asking, well, why don't we have this data? Why don't we have that data? And then you get into a really hard conversation about, well, it's because the states control this, and then the localities control this, and then and those are all reasons that have their organic roots. So I'm not saying that those aren't real, but I think that one of the key lessons, hopefully, here is that we need to resolve some of these jurisdictional issues and figure out how we're able to respond, to a next crisis in a way that helps us, perhaps just on an emergency basis, cut through a bunch of that. And I think that, as the pandemic unfolded, we did do that, with the emergency declaration and being able to cut through some of that. But, being able to do that in a little bit more, sort of proactive way next time, I think is one thing that seems like is an important lesson. The other thing I think is that, we don't have, and I'm sure there are many plans that are sitting on shelves somewhere, about what constitutes emergency response from a nationwide perspective with a very fragmented and decentralized healthcare delivery system. What does that mean? And how do we put that into action? And are there ways that now, given the base of electronic health record systems we have, for example, that those should be brought into the picture immediately in a very direct, and meaningful way, and not the way they are right now, I think, as, sort of just a reporting mechanism. So, for example, are there ways for us to think about, sort of tiers of emergency response and have participation of provider organizations in those tiers, where a first tier might be, this is the kind of reporting that needs to, come out of those systems for a tier 1. And then for a tier 2, it's, related to situational awareness and supply chain kind of data. And tier 3 is, more about hotspotting. And tier 4 is about individually identified information, because public health needs to be able to identify individual cases in as near close to real time as possible. I mean, I'm just, thinking out loud here, but it just feels like that, creating that, now that we have the benefit of having invested in all of these systems, it feels a little bit like we haven't, sort of come back now to say, all right, now we have this foundation. Let's think about how we leverage that foundation in the greatest way possible. And I think, and one point that got buried, I think, in what I just said is, we have interoperability, as I described. We discovered that we have no interoperability for situational awareness and supply chain kind of information, right? And we have to create that on the fly using spreadsheets sent into, Washington or wherever it was. I think everybody over every day, people filling out spreadsheets, literally. And I think now we know that we need to have some kind of interoperability for situational awareness. How do we define that? There's work with SANER and a number of organizations that have tried to define that. how do we put that into place and then have a process for when that kicks into gear to on demand in emergency situations.
Okay. Well, just one last question, I guess. We know that there's more money that's been, approved by Congress for modernization. And, if you were a state health official or, head of one of the city health departments that receives direct funding too from CDC, and you get the guidance, from CDC on here's the allocation, here's the plan we're looking for, et cetera. What's sort of the first thing, if you think about it, it gets in your hands and, that sometimes, plans can develop, as we've talked about silos, I think in every breakout that we have, what's the first thing I think you would do to sort of ensure that that plan is truly reflective of a good process, comes out of a good process that does achieve a truly modern, transformative public health data ecosystem? So if you were sitting down with your team, what's like or would you, what would you do? I guess the first thing tactically.
Yeah, I guess, so very hypothetical question, but,
very, yeah.
But, a couple of things that I would do and maybe offer an example. I guess the first thing I would do is, is strongly recommend that, that you just set aside your preconceptions about how that money needs to flow into existing programmatic categories. And I'm just leaving aside for the moment that maybe it has to because it's earmarked in that ways and there are regulations around it, but just being able to step back and say, how would I really want to spend this money in a thoughtful way that takes advantage of all the new technologies that are in place and that are going to be in place, 5 years from now, right? Always looking ahead because you have to look ahead. That's how long these things take. Right. And being able to, sort of think broadly about that and then thinking about how those investments get made to take advantage of that. One of the concerns that I have is that, with the amount of money that we have floating through right now, for very good reasons, right? I mean, that money is absolutely necessary. We have underfunded public health infrastructure for way too long. I think all of us would agree with that. And so, so the resources are absolutely needed and desperately needed and need to be applied. One of the concerns I get is, I have is just that, that there's a tendency, an organizational tendency for those dollars to just flow through the existing programmatic channels. And I know, I mean, the CDC and others are doing a tremendous amount of, really great work to sort of say, hey, wait a minute, how do we think about data modernization? How do we think about these things, which is fantastic. I think that, needs to flow down to state and local entities too, to say, well, how do we locally think about that in a, sort of more expansive kind of way? And to take advantage of the capabilities that are in place. There's some work that we did in my previous life with the Boston Public Health Commission, where, and this is an example of how you can see something, evolve over time. They had promulgated a regulation in 2006 to get clinical information out of the systems of hospitals and health clinics in Boston for the purpose of gathering that data to measure healthcare disparities, because there were high-level data that there were a lot of healthcare disparities in the city of Boston, but they didn't have the ability to pinpoint it. And that's an area where they said, we want to be able to do that so we can reallocate public health dollars appropriately. And that regulation literally sat on the shelf from 2006 because there was no way to implement it. There was no way to have scalable ability to get clinical data out of the various EHR systems because they were big patchwork of systems, they weren't standards. Then what they did is in 2013 or something, they dusted it off and said, now we have a foundation of EHR systems. Now we're going to put in place an opportunity, the ability to get CCDs out of those systems, and then, be able to have a modern platform to be able to run the kind of analytics we want to do. And that's a project that's underway with the Boston Public Health Commission that takes advantage of the systems that are in place and, says, now let's have some fresh thinking about how we move forward.
Well, thank you so much. We appreciate it. Thank you for joining us. We look forward to your, continued leadership and the new energy you're bringing to this effort and your collaboration with CDC. We look forward to continuing to work with you on this, because this is certainly a long process we're all very involved in. So And I can't wait for the Connect-a-thon too. So we'll be watching for that announcement. So
all right, look forward to seeing you there.
Thank you so much. Thank you so much.
Thank you, and thank you to the entire ASTHO community. Really appreciate your collaboration and look forward to more of it. Thanks.
Yes, anytime. All right, so everyone, thank you all for coming. I think so much we've learned today, so much that's exciting. My head's spinning with so many different ideas about, enterprise issues, how we connect the dots and further bring life to, I think, public health data modernization, the vision we have and the future we want for ourselves, for public health, for technology, data company partners, and most importantly for communities, especially those communities that are experiencing the negative impacts of health inequity, and we can't lose sight of that as we modernize. So I encourage you to share your thoughts and insights with us, as well as your feedback on the Texpo event survey. You can click on the tab at the top of I think either this screen or the auditorium screen to give us your input via the event survey. Your insights on this meeting are critical because we certainly hope that this will be the first of many tech expos to inform the long-term modernization and evolution of public health and how we keep it sustainable. So we aren't done yet. I encourage you all to engage in ongoing networking and follow up with those you've connected with today. Up next, we hope you'll take advantage of the 5 networking lounges that will be open from 6:20 to 7 o'clock. Please join us in the auditorium to select your discussion group. Those networking lounges are drop-in discussions on topical areas of interest where you can continue the conversation. At this time, you can return to the auditorium where ASTHO Vice President Ava Mason will provide further instructions. Thank you all for your time. Thanks for being here with us in our first Texpo. We hope it provided you a lot of value, and ASTHO is here if you need anything, and we look forward to the future. Have a great night.